Okay, we now move to Uday Devgan. Again, the next topic for Dr. Uday Devgan, IOL exchange technique.
Now I'm away. IOL exchange techniques here. So there are a lot of ways you can remove a lens from the eye. One I want to show you is something a little bit different, which is this twist and out technique. So it's very easy to do. Certainly I'll show you a video with a resident trying it for the very first time. The old way was cutting it. If you do cut it, don't cut 100%, cut 90. And then when you remove one half, the other half is still attached, so it'll come out easily. So you can pull out one half and then rotate, and the other half comes out too. So it's easy. So that's a low definition video because I don't do that anymore. Now I do this, twist and out. So you just use one haptic outside the eye, 2.8 millimeter incision, anterior chamber is full of viscoelastic. Use a spatula to protect the endothelium and to help curl the lens. Start with tying forceps and then just start with the hand supinated and rotate your hand and you'll roll up the lens inside the eye. Rotate, rotate, rotate. And again, this is a resident doing it for the very first time. And you rotate the lens a little bit more and you can pull it out of the eye very easily. Done. Comes right out. So easy. So again, an easy technique to learn. It's something that was very useful because these days we're doing more and more. Here's a video of the same case with a resident doing it. Tying forceps, rotate, 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 it comes right out. So if you get better at this, you can do even a smaller incision. So again, rotating it, rotate, rotate, and then once it's curled up, it comes out. Now you need the spatula so you protect the endothelium. Don't scrape the optic against the corneal endothelium, of course, that'll be bad. So that's a nice way of exchanging the lens or removing it with this twisted out. So again, one more time, hold it with the tying forceps, spatula to protect the endothelium and help curl the lens. Start with your hand supinated and then just rotate your hand and then pull it right out of the eye, just like that. So that's an easy way to do it. Now, sometimes you got to do a little bit more than that. Let me show you this. So in the case here, now we'll put a sulcus lens in, or even in the bag. Here's a 3-piece lens. You remember the 7L rule, leading haptic should look like a number 7, trailing haptic like L. As you know, it should never look like S. S is stupid, and I don't want to be stupid. So here I'll put it on top of the iris, and then we can dial in the haptics into the capsular sulcus, so ciliary sulcus, and then the lens is there. So here's another exchange. Here's a patient with some trauma after IOL surgery, and the IOL is actually falling in the vitreous. So we'll make it a pars plana incision here, 3.5 millimeters back or 3 millimeters back. Go with the MVR blade and put viscoelastic behind it. And now let's bring the lens up into the anterior chamber of the eye. So holding it here with forceps, you don't want it to fall back. Inject more viscoelastic and you can bring it up. And again, this is a resident who's operating and doing a great job. Same technique here. Make a main incision for the surgery. That's 2.8 millimeter keratome. And then bring one haptic outside the eye. And then twist it out. It comes right out very easily. So easy enough to do. Here's another case where you can actually uninject it. So here's using an injector cartridge and you pull the lens into the cartridge backwards. You can explant it that way too. So again, there's the lens and you're using special long nose forceps here, very long forceps. So you can grab it here and then you can pull it into the injector cartridge. You can uninject it, the opposite of injecting it, and it'll pull it up into the injector and you can take it out of the eye. Just look at that, just like that. So the opposite of injecting it. You just need to have the very long forceps that can go inside there. So again, a very interesting technique here. It certainly works very, very well. Here are the little forceps. And again, you need to have a very long forceps because it has to fit. These are the Fukuoka forceps from Japan. And you can see it goes into here and then you can grab it and pull the lens back out just like that. So again, just a nice, easy way of removing the lens from the eye. Now we're doing a lot more lens exchange now because we're probably not doing a great job of setting patient expectations. All of our technology lenses, especially trifocals, are great, but they have limitations. So I have to explain that. So here's a patient now. What's this? This is a patient that's phakic, but with a phakic IOL that's causing a cataract. So how do you remove a phakic lens? So for this is the Visian ICL. First thing is get it out of the sulcus. So get the whole lens up, and there you can see it is. And the easy way to remove this is, and through a 2.8 millimeter incision, is we're just going to use some forceps here, and we can grab it and pull it out of the eye. Now what I like to do here is rotate the lens 90 degrees. It's a little bit easier to grab. And once we do that, we can extract it from the eye pretty easily. So when you rotate it, it's going to be easier to grab this edge. So we're going to rotate the lens, grab here with the forceps, pull it out, and then get a second forceps to help hold the lens. So here, grabbing the edge, get a good strong bite so you don't break it. You want it to come out in one piece and start to pull, and then second forceps as it comes out to grab it, and there's the whole lens. It's very soft, very thin, comes out through the 2.8 millimeter incision. That comes out. Now, here's the end of the case. Looks great. IOL in the bag. A very, very myopic patient, so it's a very special lens, AR40 lens, very low minus diopter power lens in this eye. A little bit of triamcinolone in the eye. Here's all my stuff. Everything I do with cataract coach, as you know, is all totally free. So the end of the case here looks great. And then the other type is you now see phakic lenses that we're removing that are these rigid ones, the PMA lenses. I'm going to show you that. So at the end of the case, it looks perfectly fine. I just check here, make sure everything is good, and the patient's happy. Now, again, we'll make our incision here. Very easy to do this. You just remember the key is rotate the lens so that it's away, so you have a good space to grab it. And so once you get some viscoelastic underneath it, you can lift it up. And we're seeing more of these phakic lenses being explanted now. I think phakic lens is a great option for patients, especially if they don't expect it to last forever. So I think phakic lenses are great for a 25-year-old patient, and when they're about 55 years old, it's probably time to take it out of the eye and make them pseudophakic. And so again, here, lifting it up very carefully, don't damage the capsule. And then again, we can hold on to it. I'll pull it out of the sulcus, and then we'll grab it with the forceps, and we can extract it pretty easily. So in our practice, yeah, we're seeing more and more of these. For me, this is every month we see patients with phakic lenses that need to be removed. And of course, these patients can have actually a much better visual outcome with pseudophakia. And you can see this is typical to causing some kind of anterior cortical cataract as the eye ages and the anterior to posterior dimension of the crystalline lens increases. So once we have the edge exposed, we can grab it with the forceps here again. And once it's grabbed here, we'll pull it out of the eye. So if you need to, put more viscoelastic. But again, lifting this up a little bit, grabbing it. And once you get you can tell me use two hands, lift it up, make sure you get the edge. And then once you have a good hold on it, the lens is so soft and thin and flexible that you can really just extract it out of the eye here. So good grab, pull it out, second forceps to help hold it here. There you go, one forceps, there's the other, there's the whole lens, and it comes out of the eye very easily. And again, so you'll definitely see these in your practice, and easy to do. Here's the end of the case. Again, very low dioptric power, minus power IOL, and therefore it's only in a three-piece design. In the USA, we don't have minus power lenses in single-piece design, only three-piece. And these are also meniscus designed. So sometimes, though, if you're doing a lens exchange, you have to extract the lens or dissect it from the bag. This patient had a trifocal lens put in more than 1 year ago. And so how do we get it out of the eye? Patient doesn't want it. So we'll make an incision here. We're going to go back inside the eye. Now, the key is to get under the rhexis edge. Here's a needle, 27-gauge needle with dispersive viscoelastic, like Viscoat or Okicoat or Endocoat. And then once you get a little bit under there, you can open the edge, and you have to dissect 360 degrees. You want to separate the anterior capsule from the posterior capsule. So where they're fused together, you have to open it. And then remember, too, this lens in particular, the haptic has a bulbous tip, so it can get stuck there. So you pull out one haptic, which comes out pretty easily. The other one may be stuck, and you just have to take your time and dissect it. And this is a case where you've heard me say it before, viscoelastic is cheaper than vitreous. So put more viscoelastic, don't damage the capsule. In this case, we're very fortunate. The capsular bag is still intact, no YAG capsulotomy. But when I pull this, it's a little bit stuck there, so you got to take your time to dissect it out. And now, once it's dissected, more viscoelastic behind it to protect the bag, viscoelastic in front of it to protect the cornea, pull one haptic out, and now I'll go to just straight tying forceps. And then I'll use the chopper end first to grab the edge of the optic to get a better grip on it. There's a good grip. Now my spatula, and then start with the hand supinated, and then just pronate your hand, rotate, and pull it out of the eye very easily. And in this case, this patient also had dysphotopsia, so in this case, we're going to put a three-piece silicone lens in the capsular bag. opposite incision just to help clean up some astigmatism. She has about a half diopter of 0.75 astigmatism in this direction against the rule. Here comes the lens, 3-piece silicone lens. If they have a lot of dysphotopsias, the silicone lenses, while they're not usually the best choice, I think they have the least dysphotopsias. At the end of the case, it looks pretty good. So again, very important that you're youngsters and you have to learn how to do a nice IOL exchange. And again, we do these very frequently in our clinic. Usually it's from dysphotopsias or patients who don't like the lenses. Now here's a patient who already had a YAG capsulotomy. So another patient who has a different style of bifocal or diffractive lens, not happy, and you can see the YAG has already been done. Cataract surgery was 2 years ago, YAG was 1 year ago. And now we're going to get this lens, we got to do a lens exchange. How do you do it here? Well, the same kind of concept. So you can see the YAG has already been done. You're going to get some vitreous prolapse. So start with dispersive viscoelastic with the needle to get under the rexus edge. And then once you have that edge, inject more viscoelastic. And there's a visco dissection, a nice viscoelastic wave that's going to help protect too much vitreous prolapse. So go the same direction. And then we have another para on this side so you can access here. You need to have 2 paras so you can access everything. Now here's a spatula just to help open up the capsular bag. Taking your time nice and easy with a spatula just to make sure, and then going the other direction as well. You want to open the bag 360 degrees. And then the same thing here. We'll get the lens carefully dissected, bring the lens up in the anterior chamber, and then we can explant it. So here's using the chopper to just grab it right here. And if it's stuck, take your time, more viscoelastic, more blunt dissection. Don't break whatever's left of the bag because you want to place a sulcus lens here. So again, you may have to take time and just be careful and do more and more dissection. And I just do a little bit at a time. And I try, if it's still stuck, we'll put in more. I'll take more viscoelastic's okay. We'll take our time. And again, you have to be patient, especially in a post-YAG eye. The capsule's already open. It's already going to be weaker. Once you get the lens up, we can dissect it out of the bag. Also for anesthesia, give a little extra anesthesia, maybe a little bit more midazolam IV, and also maybe a peribulbar or subtenon's block. So here comes the lens. We can grab it with the forceps, make sure it doesn't fall back. Remember, the posterior capsule is open. Bring the lens up in the anterior chamber of the eye, bring one haptic out of the eye, and we'll do our same technique here of twist and out. And so grabbing the one haptic, pulling out of the eye. Now grab the optic at the edge, get a good grip, put the spatula across to protect, and rotate and pull it right out of the eye very easily. And here you're definitely going to need to do at least some anterior vitrectomy. Make sure you know your settings here. And once you clean up the vitreous, then we can put our sulcus lens in, and the patient can have a nice outcome here. Just make sure when you tell the patients, if you're taking out a trifocal or multifocal lens, they have to understand, yes, you can make their glare and halo better, but for sure, they're going to lose all ability to see up close without glasses. They have to be prepared for that. And so here's, again, a little bit more vitrectomy, a little more triamcinolone just to make sure it's totally clear. Again, more and more triamcinolone, and I dilute the triamcinolone. I don't use 40 milligrams per cc. I dilute it to 5 or 10 milligrams per cc. You don't need it so concentrated. So more vitrectomy here. It's all cleaned up. Check again. Take your time. Keep checking. Make sure there's no more vitreous. And then when you're sure, now put the lens in the sulcus. And again, it'll be a 3-piece lens. Same thing here. Leading haptics can go in the sulcus. There's the optic. And if you can, get an optic capture behind the rexus. Bring the pupil down. And again, patients can have a very nice outcome. So definitely learn how to do an IOL exchange. If you're a young resident, you know what the beauty of the videos is? You can learn in 1 year what took me and all the professors here 10 years to learn. You can learn in one. Because now you can see from the video, all the instructions are here. Never before in ophthalmology have we had such an incredible available library in high definition on your mobile phone anytime you want. So don't watch Netflix. Only watch YouTube. And so here at the end, bring the pupil down. And again, patient has a very nice outcome. And more triamcinolone just to be sure. You don't want to leave any vitreous behind. It looks great. Patient's going to be very happy. And here, we don't even need a suture. And we're done with the case. So I want to say, again, thank you for the opportunity here. Wait till my last lecture where you're going to be amazed when I show you the robot. That's our sister channel, Retina Rounds, if you like retina as well. Thank you.